Hello everyone and welcome to this lecture about the management of trauma and A-to-E assessment. The objectives of this lecture are to demonstrate an understanding of trauma management and to demonstrate an understanding of primary survey or the A-to-E assessment and to demonstrate an understanding of secondary survey. So first of all, what is trauma? So by trauma we're relating to physical trauma, which is an injury following an accident. And trauma is one of the most common avoidable deaths in adults and children under 45 years old. And the extent of the trauma, survival rate and all the treatment depend on the mechanism of injury. The most common cause of death from trauma is from road traffic accidents, unfortunately. But survival rates following a trauma have increased dramatically in recent years, and that's due to the seamless transition from care in a pre-hospital setting to critical care and the development of trauma teams as well. So trauma can be caused by different mechanisms of injury. They can be blunt. So the principles of kinetic energy from a blunt injury, they can be due to a combination of acceleration and deceleration forces that lead to shearing and compression of some tissues. An example of this is a Contrecoup injury, which we'll talk about shortly. And then there's also penetrating and blast injuries as well. So this is an example of a Contrecoup closed brain injury, and this one is very typical of a motor vehicle accident. As you can see from this image, the Coupe injury to the brain occurs when the brain strikes the skull at the site of the impact, so here. And the Contrecoup is when the brain hits the side of the skull at the opposite side of the impact, which is here. This type of injury can lead to severe brain hemorrhage or swelling. Intracranial pressure will increase and it can be life-threatening depending on the force of impact. So this image is pretty gory, but it's very self-explanatory. This is a good example of a penetrating injury. And it refers to a foreign object penetrating the body and causing damage. And this can be as a result of intended harm towards another person, so from stabbing, shooting, spearing, or by an accident like impaling yourself on an iron fence. The severity of the injury would depend on the type of object that was involved, and more importantly, whereabouts it penetrated you, and what kind of structural damage it's done inside. Now, there are many different types of trauma, but some more than others would indicate a suspicion of major injury and the need for prioritised treatment. Now, there's a long list of them here for you to read through, but all of these would be prioritised and sent to specialist trauma centres where possible. So, for example, we've got ejection from an automobile during a crash. So if someone is ejected from the car, so the car was rolling over and they were ejected from it, we know based on the type of trauma that there would be a suspicion of a major injury. That's if they even survived. Again, falls higher than 5 meters would indicate a degree of suspicion of major injury. And the speed of the crash as well. If there was a high-speed vehicle crash over 80 km an hour, we would be very suspicious of a major injury there. So in addition to the initial injury, trauma patients can go on to deteriorate further. And it's common for critically ill trauma patients to suffer from hypothermia, acidosis and coagulopathy, so a blood clotting problem. Now, when these three occur together, it's known as the trauma triad of death. And these patients are associated with an increased mortality rate between 35 and 90%. And it's because these three feed off each other, the hypothermia and then the coagulopathy and the acidosis, and they result in an acute coagulopathy of trauma. So bleeding promotes more bleeding in effect. So trauma situations are a matter of life or death, and the highest mortality rate from trauma comes in the first hour of a trauma, so prompt care is paramount, and this is called the golden hour. So there's a number of different processes in place to ensure that the patient receives rapid treatment. Pre-hospital care includes advanced level or ICU paramedics, and they can initiate treatment right at the roadside if it was a motor vehicle accident. Then there's ambulance transfer or helicopter transfer as well. And it may be if someone had a road traffic accident in Mandurah, that an air ambulance would come down and transfer them straight to the specialist trauma hospital in Perth, which is Royal Perth. Now, structured care in the form of primary and secondary survey also ensures that a comprehensive assessment takes place of your patient, and we'll go on to discuss them in more detail later in this lecture. And there's the specialist trauma teams, as I mentioned, trauma hospitals as well in place, and they've got specific training in the management of trauma. So every hospital has a trauma team, and staff members are assigned to this time on a shift by shift basis, and they're given a role according to the level of expertise. And trauma teams are multidisciplinary and include doctors, nurses and various other specialities. And it's the most senior doctor who usually plays the role of the team leader, and they're the ones that should be hands off, and they should stand there and observe and direct the flow of the trauma and the resource. And there will always be a nurse for airway, breathing, circulation, scribe, a drugs nurse and doctors as well. And most hospitals now have a trauma response policy which should outline the trauma team for the specific area. And there will obviously be less people in the team if the trauma would be, and the trauma would be handled very differently if you were working in a remote area. There may just be one or two people dealing with a trauma, which becomes very challenging. Moving on to primary survey now. So what is primary survey? Well, it's your A to E assessment, and when we talk about airway, we refer to airway and C-spine immobilisation as well. And breathing, we'll discuss these in more detail. And circulation is with hemorrhage control. Disability and E for exposure. So looking at airway in a bit more detail, we're referring to airway management with C-spine control. An airway always takes precedence in a trauma, because without an airway you would be dead. And of course, if we're performing any airway manoeuvres, we must be sure to protect the C-spine as well, because C-spine trauma can occur in 1.5 to 3% of all trauma cases, and it can lead to permanent disability. And there's also a risk of aspiration, so early intubation may be necessary, and antiemetics such as Maxilon given to prevent any aspiration in a trauma situation. So when we're assessing our patient's breathing, we must do that using the Ripper format. We're maintaining some structure. So what rate are they breathing at? Is the equal rise and fall of the chest when we're looking at them? If not, it could indicate life-threatening tension pneumothorax, so urgent intervention would be needed. And we can suffer from many different types of life-threatening chest injuries. For example, tension pneumothorax, which we'll discuss in more detail on the next slide. A massive hemothorax, which is where there's a huge amount of blood in the pleural cavity. And flail chest is another life-threatening type of chest injury, and that's where a section of the rib cage detaches from the chest wall due to trauma. These patients are all usually cared for in intensive care. Cardiac tamponade as well. This is where blood or fluid in the pericardium compresses it gets into the pericardium, and it compresses the heart. Now, cardiac tamponade can occur from trauma, so from a stabbing. That's probably the most common cause of cardiac tamponade, and for any heart surgery as well. So let's have a look at tension pneumothorax in a little bit more detail. Well, here's a great image. And as you can see, it shows that air from a ruptured lung progressively fills the pleural cavity without means of escape. And it's usually because there's been a nick in the pleural membrane, maybe here, and there's a flap of pleura that keeps closing over and trapping the air inside the pleural cavity. The air pressure keeps building, and it compresses this lung. You see all this lung tissue is compressed, and it results in a mediastinal shift eventually, which compresses all the mediastinal tissues, and this results in decreased venous return and death if not treated promptly. And the way to treat this is by chest needle decompression, which is where you insert a large bore cannula into the second intercostal space, mid-clavicular line, so about here. And it's really amazing when you do this, you get an immediate gush of air coming out as the lung is trying to re-inflate and this air is being released. So back to the A to E assessment, now we're on C, circulation. And in our circulatory assessment, you would be assessing the central pulses, so the femoral and the carotid. And we'd be checking for rate, for rhythm. Is there a pulse? We'd be looking for bleeding as well, and if there's any bleeding, we need to stop the bleeding. And if the patient has lost a lot of blood, the tubes or the vasculature, they're going to be empty, so we need to fill them up with more blood. So our patients will need fluid resus because they're being hypovolemic shock. Now, interestingly, blood loss can be massive from a fracture. For example, a fractured pelvis can be life-threatening. We can lose up to 3 litres of blood from a fractured pelvis. And it's for this reason that paramedics all have access to pelvic braces now, which helps to slow or stop the bleeding from any pelvic trauma by stabilising it. But we can also lose quite a lot of blood in our femur. We can lose up to 2 litres. So if you had a fractured pelvis and a fractured femur, we could bleed to death. Now, when it comes to disability, our assessment, we've got 2 types of assessment that we generally use. We've got the AVPU and the GCS. So the GCS is a more in-depth assessment that we tend to do in the acute settings or in the emergency department. The AVPU is a neurological assessment tool designed to be done in a trauma situation. So we're getting a rapid assessment of the patient's neurological status. So it's called AVPU because A stands for alert. So is the patient alert? Or V, are they responding to your voice and your voice only? Or pain, are they only responding to pain? Does that mean they're not alert and they're not responding to voice? And U stands for unresponsive. That means that your patient is not responding at all. And we also need to do our pupillary assessment as well. So looking at this image, this is a really good example of a unilateral fixed and dilated pupil. So when we check our pupils, we need to assess for their equality, whether they're reacting or are they fixed. And as you can see in this situation, this could indicate that there's something going on neurologically. There could be a bleed in the brain. Now, when we're exposing our patients, we need to remove all the clothing and we need to log roll them. Okay, we're going to be log rolling a trauma patient because we still haven't ruled out any spinal trauma. And you never know what lies behind. There could be a whole pool of blood underneath our patients Remember, with all your patients, you have never exposed them until you've seen 100% of their body. So once we've done our primary survey, we move on to our secondary survey, which is a full head-to-toe assessment of our patient. It's a much more in-depth A to E assessment. We literally start from the top, from the scalp, and we work in a systematic manner to assess our patients from top to toe. It's important to add that a secondary survey must only be completed when the patient is stable, and it may take many hours to stabilise a patient before you can move on to an in-depth secondary survey. I hope you enjoyed this lecture. Thank you.